Good morning, everyone. I'm Dr. Ria Shah from Sassoon General Hospital, and today I want to discuss with you an interesting case that we came across a few days back. So tell me, how many times have you been in a situation where the airway examination looks just fine, but it turns out to be a nightmare later on? Not quite often though, but isn't it a dreadful situation to be in? Here's one such case that we came across, and I would like to tell you so. A 35-year-old male, young, lean male with past history of bronchial asthma and hoarseness of voice since late adulthood presented to our casualty with post-auricular abscess. A diagnosis of query tubercular abscess was made, and now this patient was posted for debridement. A routine IV induction was done using propofol 2 mg per kg and followed by scoline 1 mg per kg. Now on direct laryngoscopy, the vocal cords appeared normal and were CL grade 1. An endotracheal tube of 8 mm was tried to navigate through the vocal cords, but we couldn't. So we re-attempted with a 7.5 mm tube, which we failed as well. So now we decided to oxygenate the patient to using bag mask ventilation and then proceed with a smaller diameter tube. Few seconds into the bag mask ventilation, the patient started desaturating and his capnograph now suddenly hit the baseline. The end tidal CO2 was now 0. We realized that the patient is in a lighter plane of anesthesia and we could see spontaneous respiratory movements. Though on auscultation, the chest was silent. We were very certain now that we are dealing with laryngospasm. Immediately, the depth of anesthesia was increased using propofol 2 mg per kg stat dose, followed by which we performed a Larson's maneuver where you give pressure in the laryngeal notch, upon which the laryngospasm is relieved, which it did. And so now we went ahead to intubate the patient with a ventilating bougie. A 6.5 mm endotracheal tube was now threaded through it and the patient was now handed over to the surgeons. Post-op, on extubation, the patient was observed for around 30 minutes for this laryngospasm. We also sent an intraoperative specimen to the histopathology for reports. 2 days later, we received a report saying it is Kimura's disease. We now got a head neck MRI done to actually locate where the problem is and why did we face the difficulty in intubation. The MRI revealed a subglottic growth. So friends, in situations like these, the management of difficult airway remains one of the most challenging tasks of the anesthetists all over the world. The cornerstone of successful management of difficult airway lies within thorough knowledge about the DAS 2015 guidelines and acquaintance with an array of airway gadgets and adequate knowledge about management of acute laryngospasm and bronchospasm. We cannot overlook these things, but sometimes the unexpected happens. So always be prepared for the unexpected should be the motto every anesthetist should live by. Thank you.